Welcome to Research Conference today. It's nice to see a nice crowd here. We have the pleasure of having a number of our DCRI fellows present today, and we always enjoy having fellows present, and I think you'll see in the second half of this academic year, you'll see more fellows presentations as we try to have all the senior fellows present, with their mentor before they graduate from the program. I will say that we're kind of doing a comprehensive relook at the fellowship program after I took over as the fellowship director this past summer, and Renato Lopez and Brian Smith are working with me as associate fellowship directors, and we actually would like the opportunity maybe in the wintertime to do a whole presentation on the fellowship program and where it's going and, and updates on that. I think there's a lot of exciting things to be done and that are still going on right now in the fellowship program. Today we'll have 3 fellows presenting. We're going to run this much like you would run an abstract session at a major meeting. Each of the presentations has been presented beforehand at a previous meeting, so they promise that they're well polished. They're going to deliver their presentations perfectly as they've all asked to. But they've all, all these presentations have been accepted and presented before, and they represent a nice body of work. The fellows here are very productive. They're involved in many different projects. I think if you look at their productivity and what they're doing during their 2 years here, it's really amazing, and it's nice to highlight their accomplishments today. We also are going to have a practice session on Thursday morning for fellows who will be presenting abstracts at the upcoming AHA meetings which start this weekend. So we'll hope some of you can join us for that. The first presenter is Emil Fosbøl from Denmark. He's joined us this past summer as a AHA PRT Outcomes Fellow. He has received his MD and PhD from the University of Copenhagen in Denmark, and has done a lot of nice work in the Danish databases before. And his presentation was presented actually at the recent European Society of Cardiology meetings, as well as some meetings within Denmark. So we'll have Emil present, and then we'll have questions after his, and then we'll go through the next 2 presentations in the same manner. So, welcome.
Yep. I'm on, right? Yep. Thanks for that, Matt, and thanks for all for having me. I've been here for a little over 4 months now, so I'm just having a great time so far. I can still screw it up for the rest of the 2 years, but so far it's good. I've only been here for 4 months, so this work is what I've been doing back home in Denmark before coming here. And my PhD thesis was on NSAID use and cardiovascular risk, and this is kind of a continuation of that. Sadly, I don't have any disclosures, so I'll just go on to the background. Very briefly, or just before the millennium, a new generation of NSAIDs were introduced to the markets. They were called the selective COX-2 inhibitors, and they were designed to reduce the very known fact that the old NSAIDs increase the risk of gastric bleeding. So the new drugs were designed to reduce the risk of gastrointestinal bleeding while still preserving the pain-relieving effects. They were sold in large numbers very quickly, these selective COX-2 inhibitors, but already within 2 years of the first drug coming on market, the first large trial showed that compared to one of the older NSAIDs, the newer drug called Robb Kociol or Vioxx increased the incidence of myocardial infarction. And 4 years after that, another large trial showed exactly the same, and Vioxx was withdrawn from the market in 2004. And that made a lot of stir. A lot of other studies focused on this as well, and more or less showed the same, and also focused on some of the older drugs, the more commonly used NSAIDs that has been used for 20 or 30 years. And drugs such as diclofenac, ibuprofen were also linked to increased cardiovascular risk, especially myocardial infarction. So one of the natural hypotheses were that these new drugs, being that they are inhibiting COX-2 more than COX-1, are increasing the risk of thrombosis. So that's kind of the main hypothesis why this link was observed. Just to put this into perspective, these drugs are very commonly used. They're available over-the-counter medications in a variety of countries. Just for In Denmark, where I'm from, these drugs are used by up to 60% of the entire population in a 10-year period. So it's very, very commonly used drugs. However, common for all the previous studies is that they've been focused on cardiovascular risk, and there's really no data to support that this should be specific, or this link between NSAIDs and cardiovascular risk, if that should be specific to the cardiovascular system or bed. And there's almost no data on healthy people, which is kind of the general consumer of these drugs. So our aim was to examine the risk of cerebrovascular risk or stroke among healthy individuals, or presumably healthy individuals in Denmark. So for this purpose, I hope you can see this, we had a core population, all Danish residents aged 10 years or more, on the 1st of January 1997, and we followed them to the end of 2005. Because all Danish residents have a unique and personal registration number, you can link everything on one personal identifier, and you can do that through kind of a state-driven system. So the researcher gets access and can do all these neat things. I've really seen this coming here, that I come from a very state-driven socialistic place. I don't know if it's a good or a bad thing, but nonetheless, we can use these databases, which are nationwide, and link information on all claimed prescriptions since 1995, all contacts to the Danish hospital system, very, very low private, very small private sector in Denmark, which is under 0.5% of the hospitals or physician offices. And we can also get survival status, place and time of death, and also the cause of death. So for the statistics part, we use two different methods. We use the Cox proportional hazard analysis, where the exposure is entered time varying, approximating that we only consider the individuals that's exposed when they actually get the drug or claim their prescriptions. And for a second analysis to underline the results, we use a case crossover analysis, where the cases are used as their own controls, but at a previous set point in time, usually set as 4 weeks prior to the event. So because we wanted to focus your attention on only healthy people, we applied certain selection criteria. The base population of all Danes over 10 years is approximately 4.5 million people. So we applied criteria saying that, for the first, we don't want to include people who've contacted the Danish hospital system for 5 years. Kind of harsh, you can argue that, but it made the study population go from 4.5 down to 1.5 million people. Further, we didn't want to include people who've claimed a long list of concomitant medications, also stating that if they have claimed a prescription for a long list of medications, we exclude them as well, and that was 2 years prior to the date when they started NSAID treatment. Okay, and we did this the same way for healthy controls. So the final study population was comprised of just about 1 million, presumably healthy Danes. So this first table shows kind of a very brief overview of the baseline characteristics. Again, you see about 1 million people. The median age is quite young, around 40 years. And again, you can see that a little under half of this healthy population claimed at least one prescription for one of these drugs. This next table shows a little more of the results. The first column, you see the number of individuals treated with the individual drugs, so a lot of ibuprofen and diclofenac users. The next column shows the median treatment duration. So overall, these drugs are used for a very brief period of time, around 2 weeks. And again, over here, this probably doesn't say much, but this is the median dosage. But you should notice here that all of the drugs were used for a short period of time, low dosage, but this drug, diclofenac, is usually used short period of time, but usually in high doses, and that's 100 milligrams per day. Now, this first figure shows kind of the main results from the Cox proportional hazard analysis, and I haven't mentioned this, but the outcome is fatal or non-fatal stroke, so cerebrovascular risk. And on the x-axis, you see the hazard ratio. On the y-axis, you see the individual drugs listed. This is fatal or non-fatal stroke. So I've kind of drawn out the neutral point of the analysis at a hazard ratio of 1 with a vertical line, dashed line, meaning that an estimate and the surrounding error bars to the right of this line means that the drugs or the individual drug is associated with increased risk of stroke. To the left of the line, decreased risk of stroke. And the numbers out on the right are the absolute numbers. And then you can see that overall, all of these drugs are more or less associated with an increased risk of stroke. However, when you stratify for high and low doses, you can see that there's more or less a dose-response relationship. It's not that clear for Robb Kociol, Vioxx. However, the confidence limits are very wide because of low events, low number of events. And for naproxen, it's not that clear as well. So this drug over here, ibuprofen, and the next one, diclofenac, those are the most used drugs, very common, and says you can buy them in over-the-counter as over-the-counter medication. Robb Kociol is withdrawn from the market. That was Vioxx, and celecoxib, you can get that on prescription as one of the new drugs as well. Okay, and here you can see that there's a link between high doses of ibuprofen, diclofenac, and especially also celecoxib with risk of stroke. Because the hypothesis for this observation is kind of unclear. There's links or the hypothesis is whether it's high blood pressure, because NSAIDs are known for increasing blood pressure. Is it an increased risk of thrombosis? What's going on? We don't know so much about the biology between the association and outcome. So we wanted to focus also on ischemic stroke. So this next figure with red estimates and red error bars shows for ischemic stroke only. Before it was stroke overall, meaning both hemorrhagic and ischemic stroke. So this is for ischemic stroke only. You can see more or less the trend is the same. However, the hazard ratios are smaller. They're getting closer to the nil. And only if you look at statistical significance, only ibuprofen and diclofenac reach statistical significance. And if you stratify again for high and low dosage, you can see that the dose-response relationship gets a bit more obvious here, that low doses of ibuprofen, low doses of diclofenac, low doses of Robb Kociol, celecoxib, and naproxen were not associated with an increase of ischemic stroke. However, high doses of ibuprofen and diclofenac were. Celecoxib was as well, but naproxen was neutral for both high and low doses. And all these results, more or less, brings me on to the conclusions and implications that all these drugs were associated with an increased risk of stroke. However, only diclofenac and ibuprofen, and especially in high doses, were associated with an increased risk of ischemic stroke. So this kind of leads to the implications that we believe that it has to be reevaluated or thought through again whether the over-the-counter retail of these drugs is really rational. Is it, or should these drugs be reevaluated, brought back to prescription claim, or even further than that? But the bottom line is we really need a big trial comparing these agents. Whether that is feasible at all, I seriously doubt that. But together with other studies, this study showed that when starting NSAID treatment, you should really consider benefits and risk before starting it, and we feel that this is best done by a physician, not by yourself when you want to buy them over the counter. So thank you, and please.
Okay. Well, thanks for the wonderful presentation. I think highlights the value of large databases, and I think you have some unique aspects of the Danish database to have all that. Quick question before we take some from the audience is, can you just remind us how you're able to capture the information on the drug use for over-the-counter therapies. Was that all billed to the national health system so that you could get billing information that way?
Well, that's kind of a neat thing as well in Denmark, that only ibuprofen is over the counter, and it's only been that since 2001.
Okay.
So we performed the exact same study before 2001 and after 2001, and the results were exactly the same.
And your database incorporates both inpatient, outpatient encounters and medication use, which is pretty unique. We don't have a similar type of database in the United States. So questions? In the audience, I think we have a microphone here, and why don't we go in the back first, and then I'll.
So that was very interesting, a little more than a little concerning. I was wondering, there seems to be an implication of causality, but presumably there's a big role of inflammation and vascular disease and ischemic stroke. Did you try to correct for why the patients were getting anti-inflammatories? Presumably they might have had an inflammatory condition that caused them to get nonsteroidals, and this is just a marker. It's not really dose response, it's just a marker of the severity of their underlying condition.
It's a very valid question, and I get this every time. It's basically the concern of confounding by indication. Are the drugs doing this, or is it the condition for which they're receiving the drugs? You can't really 100% say that confounding by indication has nothing to do with this. But one of the strengths of this study is that you can compare the drugs in between. If you're comfortable enough to say that these drugs are used for the same indication, and the drugs are associated with a different risk in between, you make that more or less, or you get closer to that not being the case. However, it's not that clear, and I would never argue that pharmacoepidemiology like this could stand alone. You would need something to back it up, right? But for this case, you have a lot of biology and some trials not designed specifically to answer this question, but you have a lot of studies to back this up. And actually, the results are very similar. Not that many drugs for cerebrovascular risk, but for cardiovascular risk you have.
It's ibuprofen.
Sorry.
Yeah. It seems like it would be difficult to figure out a dosage for over-the-counter. I tend to buy them in 500 bottles from Costco. So I know how much I'm taking.
No, that's true as well. Remember, this does not include over-the-counter use because it's only prescription claim. So, but again, your question is still valid. You're basically asking me, how do you know if they're really taking all these pills that they're going to buy?
With the script, it's easier.
Yeah.
It's clearly easier, and people would follow directions as opposed to what's on the side of the bottle.
Yeah, I hope that, yeah. But OTC is not a big problem in this, which is kind of unique compared to a lot of other studies because OTC use of NSAIDs are very common.
So, Emil, great work. Just a quick question. Were you able to look at the distribution of use according to the presence of atrial fibrillation versus not? And if so, could you adjust, these results are adjusted for the presence of AFib?
Well, because we excluded a lot of people with any comorbidity, all patients with atrial fibrillation are taken out of it. That doesn't mean that they can have atrial fibrillation on the way to outcome. We've tried to do a lot of sensitivity analysis where we exclude, or if we do time varying covariate adjustment for things like atrial fibrillation, warfarin use, cancer. We would imagine that there's a strong link between cancer and or use of NSAIDs as well. So the results always is the same, but still you take a lot of the significance out of them. True.
One more question.
With including everyone 10 years and older, do you still see the same effect if you see the healthy 55-year-olds and over? I mean, would you get a better hazard, more powerful hazard ratio?
So you're asking if there's an interaction with age, basically, and there was no interaction with age, but you could argue that obviously the indication for a 10-year-old is different for a 50-year-old. But all I can say that there was no difference there was no effect modification when considering age.
And were there many events in sort of 10 to 30-year-olds, 10 to 40-year-olds?
Well, overall, there wasn't a lot of events. I showed one of the figures showing that the drug that's used the most, there was around 400 strokes during treatment. So not a lot of events, but the events were mostly actually in the middle age group, which are the most frequent users, around 40 to 50 years.
Okay, one more question, and then we'll...
Can you clarify, was the events that you counted, were these during the period of treatment or before or after? And you said you did this crossover thing where you looked at rates in these same people before and after the period of treatment. What did that show?
Yeah, I didn't say that, sorry. The case crossover analysis showed the exact same results for all of the drugs. When you do the time-varying exposure variables, you calculate the time duration of exposure, and you just look in that time window if they have an event or not. We've also done sensitivity analysis saying that they can have a grace period of 14 days after they end their treatment, meaning that you also count those events. The results were the same, and for the case crossover analysis, that's a case-only analysis, meaning that you take all the strokes in this population and you look 30 days before the event, do they claim any prescriptions for an NSAID, and then you look 60 to 90 days or 100 to 120 days before the event as well, see if they claim any prescriptions there. That analysis really was popular when used for telephone use and car accidents, seeing if there's a link here.
Okay, thank you very much. That was good. Very nice presentation. I think in the interest of time, we'll go to the next presentation, and Ying Xian from the Outcomes group here. He's now a AHA PRT Outcomes Fellow at DCRI since this past summer. He had previously completed his medical training in Beijing, China, and a PhD in health services research at the University of Rochester before coming here to DCRI. And he's done quite a bit of work in one of the Get With the Guidelines databases related to stroke, and previously has won awards at the AHA Q-Core meeting. And so we're looking forward to his presentation on do stroke centers, accreditation reduce mortality for patients with acute ischemic stroke. So another topic on the stroke, spectrum here, but from a different angle. So I think you're.
Thank you, Matt. Thanks for having me. So now we switch the topic to quality of stroke care. Okay. So this is my disclosure. Some background information. As we all know, that stroke is one of the third leading cause of mortality in this country. And a real challenge in stroke care in this country is that many hospitals do not have the infrastructure or organization to treat stroke patients rapidly and efficiently. So in response to this, the Brain Attack Coalition published a recommendation for primary stroke centers in year 2000. And 4 years later, the Joint Commission started certifying stroke centers in this country. So as of today, there are more than 600 Joint Commission certified stroke centers nationwide. And there are some other states that are doing their own designation process. For instance, Florida, Massachusetts, and New York State. So on this slide, we show the expected benefit of stroke centers. As we can see here, that two of the expected benefits are reduced mortality and improved long-term outcomes. As of today, most of the literature on stroke centers, they mainly focus on process of stroke care, and there's little information on patient outcomes. So the objective of this study is to examine the association between stroke center admission and mortality. So the ideal approach to answer the question whether stroke center reduce mortality is to perform a randomized control trials. So patients are randomized to either stroke center, which is the treatment group, or control group, which will be the non-stroke centers. But in reality, this approach could be problematic, not to mention the unethical part of this approach. So we have to rely on observational study. But a limitation of observational study is that, unlike randomized controlled trials, they do not utilize experimental design. So there might be unmeasured confoundings that leads to selection bias. For instance, if more high-risk patients are more likely to go to the stroke center, one might come to the conclusion that stroke center associated with worse outcomes, or there's no difference. Or if the opposite occurs, that more healthy patients go to stroke centers, the effectiveness of the stroke center will be overestimated. So in either case, the effectiveness of stroke center might be biased using an observational study. So one solution to this is to use the instrumental variable analysis, which is an econometric method that has the potential to minimize the unmeasured confounding inherent in observational studies. Seems like we go back. Okay. So on this slide, I try to show the instrumental variable. So the idea of IV is that this variable is highly associated with treatment decision, in our case, whether patients go to stroke center or not. But this variable are unrelated to unmeasured confoundings, so that this variable is not directly associated with patient outcomes. This is very similar to randomized controlled trials, where you flip the coin and determine whether patients go to stroke center or not. But the randomization process itself do not have direct impact on patient outcomes. So what kind of instrumental variable we're going to use? So on this map, we have a patient. He lived on the Westford Road. Unfortunately, he got a stroke attack. Right now, he has two options. One option is go to a stroke center, which is up on the Elwood Avenue, which is a stroke center. Another option is to go to the nearest hospital just a few blocks down the road, which is the regular hospitals. So the differential distance is defined as the distance from patient's home to the nearest stroke center, which is the line in blue, minus the distance from patient's home to the nearest hospital of any type, which is the line in red. So the differential distance is actually a proxy of additional travel time for patients who bypass the nearest hospital, and then go to a stroke centers. The reason we choose differential distance as an instrumental variable is based on two assumptions. First, as we showed before, that one of the assumptions of instrumental variable is that IV is highly correlated with treatment decision. In this case, since stroke is one of the life-threatening conditions, and most patients turn to go to the nearest hospital. And also, the New York State requires that the EMS should transport patients to the nearest nearest stroke center if the pre-hospital time is less than 2 hours. So in other words, the closer the patient lives to a stroke center, the more likely the patient will be treated at a stroke center. And the second assumption is that most patients do not know they're going to have a stroke attack, so they do not choose where they live depending on how far away it is from a hospital. So in other words, the differential distance is not associated with the severity of stroke, which is one of the unmeasured confounding in our study. Okay. So here's the data. We used the New York State Spark system from year 2005 to 6. We include patients with acute ischemia and stroke in this study. The outcome measure is the mortality, and the variable of interest is whether a patient was admitted to a stroke center or not. We have patients' demographic information. We control for age, gender, race, health insurance status, rural and urban. We used a modified version of Charlson Comorbidity Index to control for comorbidity. And we use the present admission indicator to differentiate comorbidity from complications. And at the hospital level, we have hospital teaching status and total number of beds. And this is the model we use. It's a bivariate probit model with two simultaneous equations. So on the first equation, we predict the probability of stroke center admission given an instrumental variable and other covariates. And on the second equation, we predict the probability of death. Notice this is slightly different from a regular logistic regression. for a regular risk adjustment model, we only have one equation, but for this model, we have two. Here's the result. This is a map of stroke centers in New York State. As we can see here, that stroke centers are not evenly distributed in the states. So there are certain areas there that most hospitals are stroke center, and there's also other areas there's no stroke center at all. And this is the results. So we have like 30,000 patients with stroke. About half of them were admitted at stroke centers. As we can see here, the first column is the mortality evaluated at different days after stroke onset. The second and third column shows the unadjusted mortality rates. As we can see here, that stroke center are associated with a low mortality rate. And on the right column, that is the adjusted mortality difference. Actually, this is a marginal effect, meaning that the predicted difference in probability of death for patients being admitted to a stroke center because they live relatively closer to them versus patients who admitted to other hospitals because they live further away from stroke center. Let me use the 30-day mortality as an example. So the adjusted mortality difference is negative 2.5, which means that stroke center is associated with a 2.5% lower risk of death for patients with stroke. Because we have shown before that stroke centers are not evenly distributed, so we stratified the analysis by New York City and upstate New York. As we can see here, that the adjusted mortality difference is very consistent, still negative 0.% between stroke centers and non-stroke centers. And we also stratified the analysis by race group, race ethnicity group. As we can see here, that in each race group, stroke center is associated with lower mortality rates. The only difference is for the other race group. Although the difference is negative, that difference was not statistically significant. So far, we have shown that stroke center is associated with lower mortality. But we still don't know if it's the stroke center reduced mortality or if it's because hospitals that have better quality are more likely to participate and become a stroke center. So to answer that question, we look at mortality rates for patients with GI hemorrhage or AMI who are admitted to stroke centers. The idea is that if the hospital has already made a commitment to quality improvement, we would be able to see not only lower mortality rates for stroke, but also for other life-threatening conditions, for instance, AMI or GI hemorrhage. But actually, that is not the case here. As we can see here, that the adjusted mortality difference is actually positive, even though the difference are very small and not statistically significant. So meaning that for those two conditions, stroke centers do not perform better than non-stroke center hospitals. So here's the limitation. First, we use the New York State data. So there's some generalizability issue if we want to see stroke center in other part of the country or stroke centers certified by other agencies, for instance, Joint Commission stroke centers. Another limitation is that we use observational study, so we do not have the stroke severity measure. But as I mentioned before, one of the advantages of using instrumental variable analysis is that this has the capacity to remove or minimize the unmeasured confounding without directly measuring it. And third one is, for this analysis, we only look at mortality. There are different aspects of stroke care. For instance, process of care or other outcome measures cannot be evaluated in this study. So I really wish I will have a chance to maybe use the Gateway's Guideline Stroke Registry or the Paul Caverdell Stroke Registry, as you know that all those two registries have more clinical information, and also we have a chance to look at other metrics of stroke care. So in conclusion, we found that New York State Stroke Center were associated with a low risk of death for patients with acute ischemia stroke. And the mortality difference we have observed is sustained up to 1 year. And the mortality difference is only specific to stroke, as we do not observe in other conditions, for instance, like the AMI or GI hemorrhage. So we conclude that a rigorous process of designation stroke centers has the capacity to improve the quality of stroke care and improve patient outcomes. Thank you.
Okay. Bob?
That was very nice. I have a couple of comments and then a question. The comment, well, maybe it is a question. Why do you think a randomized trial of stroke centers versus non-stroke centers is unethical? But let me ask my other question first. What does it take to become a stroke center? And are there good stroke centers and bad stroke centers? And is there any way to consider that? And do people get paid differently if they're stroke centers? Because when I look at your AMI and GI bleeding mortality, one conclusion could be is that you could do a really good job of taking care of stroke and stink at everything else. How do you balance those?
Well, this is a real good question. For this analysis, we assume a stroke center as a whole. So we assume that everybody perform similarly. Of course, that could be different. For instance, something I didn't show here is that actually teaching hospital and a large number of beds associated with better outcomes. So even though they all stroke centers, they could be different. So large teaching hospital could be a better indicator of quality of care. And so in order to be a stroke center, they have to follow the brain attack correlation recommendation, which is around 11 different elements criteria. Joint Commission use that criteria, New York State use that criteria, even though they might some slightly difference in their details.
So people could be a good stroke center or a bad stroke center. We don't know that.
That is possible. Actually, one of my questions is that since year 2006, New York State, 2005, they start certifying stroke centers. They are booming. Okay. At the beginning of year 2005, I think there are only like a dozen of them. And right now, there are more than 100 of them. So the question is, are all those stroke centers the same? This is something we didn't have a chance to look at in our study. But that is a very good question.
And why do you think it's unethical to randomize people to go to one place or another?
Okay. Let me show you this. This is something I didn't show before. So look at stroke center and non-stroke centers. The distance from patient's home to the stroke center are quite similar. It's about, on average, the median is about 3 miles from patient's home to the stroke center. When we look at differential distance, the differential distance for stroke center is actually 0, meaning that the reason they go to stroke center is because that is the closest hospital to their house. When we look at non-stroke centers, that is 11 miles, meaning that if the patients, you want to bypass the patients to the nearest stroke center, you have to drive additional 11 miles. So it's probably unethical just because of randomization, we drive further miles for those patients. And also because assuming that stroke center doing better quality of care, it's unethical that some patients have to go to other hospitals. It's providing a low quality of care. So that is my guess.
I won't argue with you here, but I don't agree with you.
Yeah. Just to get your other questions, Bob. One is that you get paid nothing additional for being a stroke center. Matter of fact, you got to pay more. The only benefit potentially economically is that if your care becomes more efficient, you discharge sooner and you make more on the DRG. But in terms of reimbursement, there's no difference.
But there's got to be some care because people don't do things.
Yes, if you looked at the map there of New York, the same thing is true in North Carolina. You get one stroke center, there's a hospital up the block. They got to become a stroke center because it's market forces and nothing to do with organization of care. That's really driving who becomes a stroke center and who doesn't.
Where you're the only game in town.
You can see it there. You can see it there. Look where all the blue dots are, and look where all the red dots are. Look in New York City and in Long Island, where it's a very competitive market. The dots are on top of each other there. The other thing in terms of what it takes is that it is for a Joint Commission stroke center is incredibly rigorous. Not only do you have to report quality data quarterly, they come in, they do a tracer, they'll go down to the ED, find a random tech down there and say, what would happen if you saw a stroke patient? They do chart auditing, they talk to patients. It's a very, very rigorous process. But what we don't know is whether or not this process is affecting patient outcomes. The study that we did was a national one. We published this about a year and a half ago. What we did was we did a cross-sectional study of stroke centers over the first 2 years that they became stroke centers. And what we found was that, just as you did, that they had lower 30-day mortality, lower in-hospital mortality, and lower 30-day readmission rates. Looks wonderful, right? The program is working. But what we did was we went backwards in time, 2 years before, on average, 2 to 3 years before the program even began, even before the Joint Commission program was even an inkling in anybody's eye. In those centers were still, even 2 years before the program began, having very significantly better outcomes than centers that 2 to 3 years later would become Joint Commission stroke centers. So what we can say is that if you're a Joint Commission stroke center, you're likely going to have better outcomes. What we can't say is that it has anything whatever to do with the program. It's that what it is that those centers had the doctors, had the people that were interested in taking care of stroke patients, and just like we find that cardiologists do better taking care of heart patients, stroke doctors probably do a better job taking care of stroke patients. And that's what you're seeing. I think you're seeing this inherent bias that they did better beforehand. In terms of doing a randomized trial, what you need to do is have New York City, where there are dots on top of each other, because it's not doable anywhere else. Because the one thing we do know about stroke centers for sure is that their treatment rates for thrombolytic therapy are dramatically higher than places that aren't stroke centers. That has to do with the organization of care. And, in North Carolina now, the North Carolina EMS routes patients to places that are either primary stroke centers or that they call stroke-capable hospitals, which means that they had to have demonstrated that they can take care of these patients, at least acutely, to EMS. So the country is being reorganized along these ways. What we don't know is whether this program per se is definitely leading to patient better outcomes, or, again, these are places that already were doing better anyway.
So it would seem, because there is a big policy debate as to whether or not there should be, for many diseases, there should be centers of excellence and sort of consolidation of care. It would seem that before we make that assumption, that we ought to test it to see if people actually are getting better care.
And so far, the process measures, if we measure them with get with the guidelines, the problem there again is that who does get with the guidelines? It's hospitals that it takes a lot of time, a lot of energy, and a lot of money to do this. So these are places that are already committed to improving their care. So if you do a study like that, yeah, they're already going to be doing better. Again, whether we can show that these centers make a difference, don't know that. They're better, but whether it's because of that or just because they be that way.
Great discussion. So let's move. Thanks, Ian.
Thank you.
To our last speaker. I'd like to invite Robb Kociol. Robb Kociol graduated from medical school in 2004 from Boston University. Then went to residency at the Brigham and Women's Hospital and came to Duke in 2007 for the cardiology fellowship. Currently, he's a second-year research fellow. He's the co-chief fellow, and he's going to present some nice work that he has been doing in readmission rates in heart failure patients.
Thank you. So, just as by way of introduction, a lot of the work I've been doing since I've been here has been focusing on quality of care for heart failure patients, and particularly looking at short-term outcomes, readmissions, and mortality. And this has been made sort of abundantly clear over the last couple of years is that heart failure is an increasingly prevalent problem in the United States. It costs the healthcare system over $38 billion annually. It's the number one discharge diagnosis among Medicare beneficiaries. And then among patients that are admitted for heart failure, once they're discharged, they have a fairly high rate of short-term adverse outcomes. Up to 25% of heart failure patients will be readmitted to the hospital within 30 days, and close to 60% within 1 year. So quite a bit of post-discharge morbidity. And given that Medicare is increasingly focusing on this issue of short-term readmission, 30-day readmission, for a number of diseases that are common, including heart failure. In fact, in I believe it was June of 2009, Medicare began publicly reporting 30-day readmission and mortality for 3 conditions, among one of which was heart failure, on their Hospital Compare website. So this has generated increasing research interest as well. Over the summer in JAMA, there was a publication that looked at trends in heart failure admissions over time. And if you look at the graph, this is among Medicare beneficiaries in the United States. And if you look at the graph to your left, this shows over the last 15 years or so a steady decrease in length of stay for heart failure admissions. Whereas if you look at the graph on your right, you see a steady increase in 30-day readmission rates. And the researchers here concluded that there may be financial incentives for hospitals in our fee-for-service system that are driving length of stay down, and this is resulting in less than optimal care and increasing the risk of 30-day readmission. However, if we were to turn back the tides and lengthen length of stay in order to reduce 30-day readmission rates, we may just be shifting the economic burden from the payers back to the hospitals. So it's important to understand if there's a relationship between hospitals with lower readmission, with higher length of stay and lower readmission rates. And therefore, we designed the study with the following objectives. First, we sought to understand whether hospitals with shorter length of stay indeed do have higher readmission rates. And then we looked at the association between hospital ranking by 30-day readmission rate to understand if that was associated with total inpatient days for a 30-day episode of care as a surrogate of resource utilization. And finally, we sought to understand if there was a relationship between hospital 30-day readmission rate and other measures of quality and short-term outcomes. In order to do this, we used the Get With the Guidelines Heart Failure Registry. So this has been previously discussed, is a voluntary quality improvement registry. Trained site personnel abstract data, including demographics, comorbidities, lab values, medications, and inpatient mortality. We then link this data to Medicare Part A claims in order to have 30-day outcomes data. The population included in our analysis were greater than 17,000 patients. They were all aged 65 years or older, and they were in 149 hospitals. The dates were from January 2005 to December 2006, and we excluded patients that died in the hospital, transfers ins and transfers outs, and low-volume hospitals, so less than 15 patients. So we utilized the following definitions for our analysis. I'll just go over them with you. So for an initial admission for heart failure, we define length of stay, or abbreviated LOS, as the total hospital days for that index admission. Once they were discharged, any readmission within that 30-day post-discharge period was counted towards the readmission rate. The total hospital days for the index length of stay plus any readmission days were counted up, and that was the total episode of care in days. We ranked the hospital based on the readmission rates and the geometric means of length of stay and episode of care. And to compare these outcomes, we used Spearman correlation coefficients. We divided the hospitals into quartiles by readmission rate, and the risk-adjusted outcomes were determined by multivariable logistic regression. So this is a summary of the observed outcomes, hospital-level observed outcomes. The overall median readmission rate was 23.2%. The average index length of stay was 4 days, and the average overall episode of care was 4.7 days. Oops. In terms of the quartiles, the hospitals were evenly divided among quartiles, with the lowest quartile with the lowest readmission rate having a median readmission rate of 21.6%, and the highest readmission rate quartile at 24%. When comparing baseline characteristics across quartiles, the age and gender were similar across quartiles. There were some differences in race, with a larger amount of Caucasians being represented in lower readmission rate hospitals and a larger number of African Americans being represented in higher readmission rate hospitals. Comorbidities were similar across quartiles, with the exception of higher proportion of atrial fibrillation in the low readmission rate hospitals and slightly higher rates of TIA and stroke. In terms of hospital characteristics, they were all similar across quartiles. I showed two selected characteristics, hospital size and academic status, and there was no statistically significant difference there among the four quartiles. So just to go back to our objectives for a second, to remind you, our first objective was to look at the relationship between index admission length of stay and hospital readmission rates at the hospital level. And so you can see by the scatter plot, if you look at the y-axis, this is hospital level length of stay in days, and the x-axis is 30-day readmission rate. And as you could see there, there was absolutely no correlation between index length of stay and the hospital readmission rate. Next, we sought to determine the relationship between hospital readmission rate and overall 30-day inpatient days as a surrogate of resource utilization. And when we looked at this, there was a statistically significant correlation, but the effect size was quite modest. And finally, after risk adjustment, these correlations did not change at all. And our last objective here was to examine the relationship between hospital ranking by 30-day readmission rates and other performance measures, as well as outcomes. As you can see here, when we look at the relationship between quartiles of readmission rate versus mean composite performance measure, this is a composite of adherence to CMS performance measures, there was no consistent pattern. And actually, this held true when we looked at individual performance measures as well. If anything, there was a trend towards hospitals with the highest readmission rates performing better on certain CMS performance measures and quality measures. And next, we looked at the adjusted odds of short-term mortality, 30-day mortality, based on quartile readmission rate. And compared to the highest readmission rate quartile, there was no difference among the other quartiles that we looked at. However, when we divided hospitals up by quartile of episode of care, so total inpatient days, and looked at for example, the lowest episode of care quartile versus the highest episode of care quartile, or most inpatient days, we found that those in the lowest episode of care quartile had a 25% reduction in the odds of 30-day mortality. So this analysis does have limitations. It is restricted to hospitals participating in the Get With the Guidelines Heart Failure Registry, which limits its generalizability. The population only included patients 65 years or older, and there may be unmeasured or residual confounding factors. And the association between quartiles and performance metrics were not adjusted for. So in conclusion, hospitals with lower average heart failure index length of stay did not have higher readmission rates. And there was only a minimal relationship between readmission rate and overall episode of care. There was no consistent relationship that existed between readmission rate and performance and quality measures. However, lower quartiles of episode of care were associated with lower short-term mortality. So the implications here is that lengthening index hospital stay may not reduce readmission rates. So, and that 30-day readmission rate as an economic metric has little association with total resource utilization as measured by total inpatient days. 30-day readmission may have limited utility as a measure of quality for heart failure patients. But episode of care may represent a novel metric of efficiency and quality of care for heart failure patients. Thank you.
Thanks, Rob. I think we have time for one or two questions. Karen?
That's a nice talk. Thank you. Your data are on a hospital level as far as the analysis, and well, the analyses are on a hospital level, the unit of interest, and yet the data that you do have data on a patient level. So I'm assuming, like for adjustment, you used patient level data. Mortality was on a patient level. So I'm wondering, did you at any point look at these analyses on the patient level as opposed to aggregating them within hospital at all times.
So you mean looking at like patient level length of stay and the
Correct.
When we've looked at that before, it's on the patient level length of stay. Patients that stay in the hospital longer are typically sicker and more likely to be readmitted, which was why we sort of focused our interest here in on the hospital level length of stay. So what was the characteristic of the hospital? Did the hospital tend to keep patients longer or shorter, and how did that affect hospital level outcomes? Does that answer your question?
Jerry?
This is a minor point, Rob, but your plots, it seemed to me the question of interest was how is, or one of the questions was how is length of stay related to, or is there a relationship between initial length of stay and the readmission rate? And in your plots, you had readmission rate on the horizontal axis and length of stay on the vertical axis. It's just that, again, this is a minor point, but we typically think of the y-axis or the vertical axis as being the variable that of interest that whose relationship we're studying is a function of the x-axis. So I would think it might be sort of intuitively more interpretable to have initial length of stay on your x-axis, readmission rates on your y-axis. Sure. But that's a comment from a picky statistician.
So great. I'd like one more question.
Real quick. It looked like from the numbers there that the range between the highest and lowest quartile is still pretty tight. And that may be because, again, these are all hospitals that are voted with their feet and are participating in the Get With the Guidelines program. So overall, their outcomes may be relatively good. The problem is that CMS is going to go hog wild using mortality and readmission rates for reimbursement and as quality indicators for hospitals. What this suggests is that is just the wrong thing to be doing. But how we change the ship once it sails is not so straightforward because they don't seem to be responsive to data.
Right. No, I agree. I mean, 30-day readmission rate is clearly something that a lot of people are focusing on. I think, part of the issue right now is that if a patient's readmitted within 30 days, Medicare has to pay for it. So clearly there's a huge economic incentive for them to be focusing on that as well. The question I would have, and I don't know if this is going to happen, but if the payment system turns more towards a payment based on an episode of care, so bundled payments for a 30-day episode of care for a heart failure admission, so the accountable care organization gets X amount over 30 days, and the inpatient and outpatient providers get to split that money up how they will. How interested is Medicare going to still be in 30-day readmission rates? I don't know.
Great. I would like to congratulate the fellows for the great presentation and great work, and thanks everybody for coming.